Hello, everybody. Welcome, welcome, welcome. So let's get started on talking about this. My name's Jack. I am the Rheumatology Physio. I'm known across social media and the internet these days as the Rheumatology Physio. We're going to talk about psoriasis this evening. It's been requested a good number of times by people on my courses, but also across my social media as well. Talk a little bit about psoriasis so that we as MSK clinicians can understand a little bit about it, recognize it maybe, that kind of thing. Just while we're on that, if you have any requests for topics and webinars, etc., then do put them in the chat. If you're watching live, pop that in the chat here. If you are watching on YouTube as a follow-up, sort of catching up, then pop it in the YouTube comments. Either or, I will get around to it. I try and do these webinars every month, although I have been a little bit slack recently because I've been busy. But let's crack on talking about psoriasis. So very brief agenda here. We're going to do a little bit of an introduction to psoriasis, try and help you to understand it a little bit, what's going on, sort of what it is. Then we're going to talk about the different types of psoriasis. And finally, we're going to finish up with a little bit of information about psoriatic arthritis, which of course is my area of specialty in MSK therapies, is differential diagnosis of inflammatory arthropathies and the weird and wonderful world of rheumatology. So I'll give you a little bit of advice around psoriatic arthritis as well. I couldn't do this presentation without slipping that in at the end. So psoriasis itself. So this is an autoinflammatory skin disease. Okay, so I'm going to break that down for you. Autoinflammatory is an inflammatory reaction against the body's own cells, against the body's own structures. Okay, so typically we'll understand this from something like rheumatoid arthritis, where the inflammatory system reacts against the synovium of the joints and causes synovitis. But in psoriasis, the immune system is reacting against the skin. So this is auto, so it's directed against the skin, as opposed to what you would traditionally think of when the inflammatory system or the immune system get involved. So in the immune system, for example, it's usually reacting against things like bacteria, viruses, foreign bodies, that kind of stuff that gets into your body, and tries to get rid of that because usually they are unwanted. Or inflammation tends to be in response to tissue damage, or other places. You know, you've got ongoing inflammation pretty much everywhere, but in places like the gut, there's quite a lot of inflammation as well, ongoing inflammation. But this is an auto-inflammatory reaction, so the inflammation is occurring against the body's healthy tissues, and that is not ideal. And in this case, that is the skin. Psoriasis is related to HLA-B27, human leukocyte antigen, B27. There are tons of human leukocyte antigens. You are either positive or negative for some of them. Everybody is. But HLA-B27 positivity, so being positive for that, is a risk factor for developing psoriasis, but also other types of inflammatory arthritis, such as psoriatic arthritis, for example, ankylosing spondylitis, and other inflammatory diseases as well, things like ulcerative colitis. So HLA-B27 positivity is important. And it is also characterized by a negative rheumatoid factor. And that's interesting later when we talk about psoriatic arthritis. So a negative rheumatoid factor. So in comparison to rheumatoid arthritis, which is usually positive rheumatoid factor, psoriasis and psoriatic arthritis are typically negative for rheumatoid factor. So in old speak, seronegative, if that is part of your language. I certainly don't bother with that kind of language anymore, but rheumatoid factor negative for psoriasis. So what's happening is there's an inflammatory reaction against the skin, and then we'll see some pictures of what that causes, sort of the outcomes of that in a minute. The prevalence of psoriasis, if you look at the whole world as a unit of our entire population, don't know where I was going with that sentence. If you look at the whole population globally, psoriasis affects approximately 3% of the population. It is more common in the Western population, especially Caucasians. 4% are going to be affected by psoriasis, and about 0.5% of Asian and African populations, so a little bit less common. in those populations. So typically, so obviously presenting from the UK, we are going to see that. The Americans, the US, they have similar. Australians, so on and so forth, about 4%. So it's certainly not uncommon disease or uncommon problem, but it's certainly not, it's not affecting half the population, for example, but is fairly common, a very common skin issue. So we have some various different types. I've listed out about 4 of them with some pictures for you. I've taken these pictures from the Psoriasis Foundation here in the UK. Thank you very much for them for letting me use their pictures. And this is the most common types. This is the type you're typically going to see with people with psoriasis. About 70% of people with psoriasis is going to have this kind. And this is plaque psoriasis. And in fairness, this is the kind of psoriasis that people are thinking of most of the time when we're talking about psoriasis. And someone says they've got psoriasis. And as you can see, what you get is you get red areas on the skin, and these are covered by white scaly patches. So what is happening? The red areas are the areas of the skin that are affected by the inflammation. So you can imagine that you've got the dermal layers over your inside tissues, over your fascia, connective tissue, muscles, so on and so forth. And the red areas are where the inflammation is occurring. You've got increased blood flow, you've got increased cellular activity at that point. And what's happening is the inflammatory reaction is speeding up the turnover of cell, or the creation and turnover and aging of the cells, essentially. So what you're getting is this rapid movement through the normal cycle of skin evolution, essentially, and it's rising through the layers up very quickly. And what you then get is poor quality skin, and that's reflected by these scaly white areas and thickened, and you end up with more layers of skin. So it's thickened and raised, and that is the type of plaque psoriasis. Symptom-wise, this can vary quite significantly. Some people aren't really bothered by their psoriasis. But a lot of people are. It can be painful, itchy, sort of just really irritated. And it also is sort of irritated by various different things. Some people, it's irritated by getting wet, some friction, the cold, the heat even. Various different types will affect it. Typically, as you can see from these pictures, you're going to see this in the extensor areas of the body. So you can see the back of the wrist, or the back of the hand there, and the elbow, the extensor portion of the elbow. You also see it on the front of the knees, typically. And this is in contrast to something like eczema, which tends to be in the flexor areas of the body. So the neck, the crook of the elbow, the back of the knee, the groin. So typically you're going to see that on the extensor portions. Now, as I mentioned, some people aren't particularly bothered by this. And if it's a small area, you see that the elbow there, if that was the only part of the body that's affected, some people haven't sought treatment or diagnosis. So they might be undiagnosed with psoriasis when they come into an MSK clinic for another reason. So it is worth looking out for and keeping an eye on people's skin. And if I advocate for asking about people's skin anyway. It's of various importance in rheumatology, but I tend to ask if they've got any problems with their skin. And if they say yes, delve into that a bit deeper, and they go, oh, I've got this patch on my elbow, and you see it's white and scaly and red, and you think, actually, maybe that's psoriasis. So that's the most common type of psoriasis. Then we have guttate psoriasis. This tends to be much more widespread across the trunk, and you can see that there's a rarer form of psoriasis. I did see that good number of times when I was working in rheumatology. But some people might think that's more like a rash than sort of the plaques of psoriasis. So worth checking out people's skin if you're able to, or if they have a particular mention of that. You also can get pustular psoriasis. This is pretty nasty. Tends to be on the palms of the hands or the soles of the feet. These people will commonly be under dermatology, being strongly managed. This is not a nice variation of the psoriatic disease. Very problematic, very painful. The skin will become infected and break down. It's really not nice, and quite strong medication. Do a lot about that. And obviously this kind of psoriasis as well, you can imagine that if you are treating somebody for any issue under MSK, then you might have problems with gripping, or if it's on the soles of the feet, trying to do extended walking. So you might have to adapt exercises significantly as well to avoid irritating or causing problems with that kind of psoriasis. And then you have the confusing inverse psoriasis. So instead of the extensor portion of the body, this is now in the flexor portions of the body. As you can see there, that's in the armpit. Starting to get into rarer types of psoriasis now, but that is possible that somebody has that as well. And then one that I'm really interested in when we're talking about differential diagnosis, nail psoriasis. So you can see here, these are changes in the nails. This comes from inflammation at the nail bed. And the reason this is really important is this significantly increases someone's risk of developing psoriatic arthritis. So about 4 times more likely to get psoriatic arthritis if you have nail psoriasis versus psoriasis of the skin only. So you can see characteristic changes on the nails here. If you look at the middle finger, you can see that the nails are becoming fragile. If you look at the 4th finger, you can see there's characteristic lines, and I've got some more of those in a minute, with some more images, characteristic vertical lines along the nails. And then on the index finger there, you can see that that's very fragile, broken away from the finger. And that's really sort of later changed psoriasis in the nails. Here you can see this is some you've got across the spectrum here of change. So the middle finger here has this earlier sort of lifting away, and you can see the ridging and the lines on the index finger there, where and lifting away. So it's a bit later change. And then you can see on the ring finger there, that's really severe nail change. It's really fragile, fractured. You've still got some lines, and it's just real strong change there. And that's a lot of inflammation causing the change in the way the nails grow along the nail bed, and causing big problems. And that is really highly likely to cause someone to develop psoriatic arthritis. And then finally here, I've put these in just to see what you're up against as well. This earlier change, so you can see the thumbs on the left side of the screen. This is quite early change as we look at the screen, the leftmost thumb, that's probably the lady's right thumb there. You can see the early change where it's starting to lift away from the nail bed. And then on the thumb to the side, you can see some very early little pits into the nail where it's just starting to grow poorly and have some change. So we are looking for these kinds of changes in the nails when someone comes and attends with things like tendon problems. And then the other final image here is a picture of oncholysis. So this is nail pitting. So you can see it looks like someone's pushed pins into the nails. This is another type of nail psoriasis change that you can see. And again, you can see the characteristic lines running down that nail. So really important to be assessing your patient's nails. I'm not asking you to be a dermatologist, absolutely, but certainly having a look and seeing whether you're, I would suggest anybody attending with back pain or tendon pain needs to have their nails assessed, but you're also looking at anybody with psoriasis and having a look at their nails as well, because like I say, it has that strong association with developing psoriatic arthritis. So let's go on to talk about psoriatic arthritis for a couple of minutes. As I say, this is where my real interest lies. This is what I teach about. This is an enthesitic disease, okay, so primarily. So this is an auto-inflammatory reaction against the entheses of the body, so of the high-load tendon and ligament insertion. So as the ligaments and tendons blend to bone, that's the enthesis. That's where the inflammatory reaction is occurring. This is predominantly a peripheral disease, so you're looking at things like the Achilles tendon, the plantar fascia insertion, the patella tendon, the lateral hip, and the elbow epicondyles. So they're the heaviest load entheses of the body. They're typically where the psoriatic arthritis is going to occur. They also can get axial disease as well, so affecting the sacroiliac joints and the spine. That can certainly occur in psoriasis, although that is sort of less common to be the predominant symptoms. A lot of people with psoriatic arthritis do go on to develop inflammatory changes and pain in their spine as well, certainly if they're left untreated. It's quite a broad range depending on what kind of symptoms and demographic profiles you're putting in as to how many people with psoriasis develop psoriatic arthritis. It depends how you define the psoriasis, depends how you define the psoriatic arthritis. So at the bottom end, the 6%, you're probably looking at skin psoriasis and initial onset axial disease. Versus at the 40% end, you're looking at the nail psoriasis and the peripheral disease. So quite a high number of people with psoriasis are going to develop a type of psoriatic arthritis. And so when people with psoriasis come into your clinic, you need to be highly suspicious that they may have developed psoriatic arthritis if they're attending with pretty much any type of back pain, buttock pain, tendon pain, and or joint swelling as well. So really need to be investigating that. If you do have any further learning needs about that, then I have tons of those. A bit more on my YouTube channel, but also loads on my website as well, rheumatology.physio. And of course, run the courses too to help you with that. So peak age of onset for psoriatic arthritis is also interesting. I thought I'd put this in here too. So there's two peaks, twin peaks of age of onset. So sort of an earlier disease between 10 and 20, and then another peak at 30 to 40. Can be outside of these age ranges when people onset with their disease, but though typically the younger end, more of a juvenile onset versus a sort of more slightly later. But unlike ankylosing spondylitis, for example, there's less of a significant cutoff at age 45. So you do need to stay vigilant for it, but most people will have onset by the age of 40. So if you suspect someone might have psoriatic arthritis or you want to put it into your differential diagnosis, then you have got tools available to you. This is the Spade tool. Just type spadetool.co.uk into your browser, into Google, and that will come up. And this serves two purposes. So this will help you with asking the appropriate questions to screen your patient for all types of spondyloarthritis, really, but in this case, psoriatic arthritis. So in there, you can see there's inflammatory type back pain, heel pain, that's your peripheral enthesitis, so your tendon problems, peripheral arthritis, dactylitis, that's swollen sausage digit, iritis or anterior uveitis, those are other HLA-B27 positive related diseases, psoriasis, clearly, that we're talking about today, inflammatory bowel disease, positive family history, good response to anti-inflammatories, and if you know any of their bloods or have shown sacroiliitis on MRI. So you tick the boxes that your patient has, and then it gives you a nice little graph. And the little red dot that you can see on the graph there, that will move up and down the graph depending on how likely your patient is to have developed psoriatic arthritis. So for all intents and purposes, really, to make it simple, the more of those boxes you tick, the further up the line the red dot will go. Although they are weighted, those boxes are weighted differently. If you see in the bottom left, that's the research button. That's quite fascinating on how they created this tool. And how they weighted each of the questions. If you're a nerd like me and you like that kind of information, then you can go there and read that. But anyway, you can see that in this case, whatever I put into to that tool has shown that we need additional tests to determine whether it's a spondyloarthritis or psoriatic arthritis in the case we are talking about this evening. And you'll note that it says assessment by a rheumatologist is recommended once we get above the additional tests necessary. And there's various reasons for that. One, it's obviously the role of the rheumatologist to do that, but also it's very difficult. A lot of these diseases do overlap. And again, for a full course on that, runs to about 16 hours or something, you can learn lots and lots and lots about rheumatology from me, or of course, watch all the YouTube channel videos. Whichever one is your preference. But if you put lots into that table, then it will go up and you can go up into probable diagnosis of axial spondyloarthritis. But to be honest, it's not going to change your management as an MSK therapist. You're still going to refer off to rheumatology, or at least find someone who can do that for you. So that is the spadetool.co.uk. I would advise you go and have a look at that, have a play around, see what it does. Interesting. There's lots of other resources on this particular website as well. You can see the AXPAR, the ASAS criteria, what inflammatory back pain is, how you define that. And that's interesting as well. Although I would prefer that you got that information from me because that suits me. That benefits me, doesn't it? But there you go. You can, of course, get that from lots of places. I would advocate for this one as one of those areas to get it from. So that is the spadetool.co.uk. So if you do have any questions, if you are watching live with me now, then please do put them into the Q&A tab. That's absolutely fine. We can go through a couple of those now if there are any. If you are watching back on YouTube, then please do put them in the comments and I'll get back to you. If you have any topics that you want me to cover, then please do put them in to the comments sections as well. And I will endeavor to get to those as webinars when I can. I have a list that I am running my way through, but it's not that long. I try to be reactive. Yeah, these are good fun. I enjoy doing these. It gets me I use these as a couple of different reasons to do these. Obviously they're educational, but allows me to test some of my content as well, I guess. So any feedback that you have for me on the presentations or anything like that, then please do put that in as well. Positive, negative, ideally positive, but not everything's positive all of the time. So we haven't got any live questions, which is fine. So I'm going to leave you there. Please do have a look at my website, rheumatology.physio. There's loads of stuff on there. Absolutely loads. I've got so many learning resources these days. I keep building them. Every time I do different courses, I create new stuff. Have a look at that. It'd be very, very beneficial to me if you do. And I'll see you out on further webinars. Hope you've enjoyed that. Thank you very much.